Good afternoon, all of you. Respected Matron E in her absence and respected Yoko Kato, patron of ACNN in her absence. Dear moderators, speakers, session chairs, and participants, warm welcome to you, or welcome all of you to the 6th ACNN webinar of that young neurosurgical nurses forum webinar. And today we are highlighting and selected one of the important topic, that is movement disorder, and mainly aims at multiple targeting in movement disorder, recognizing it as a complex disorder caused by multiple etiological factors. So rather than sticking on one therapy or one treatment modalities, but using a combination of therapies to hitting multiple targets to have a symptom control. So today we are aiming at having fruitful discussion on this topic. And today we will be having a first session by a doctor, followed by a nursing session. Then we'll be having a session by Indonesian neurosurgical nurses practice about neurosurgical nurses practice from one person from Indonesia. So today, let me start in the absence of Yoko Kato. We can just directly move on to today's sessions. So let me welcome Dr. Ahmad Fahmi to chair the first session. And Doctor is the in the Department of Neurosurgery of Dr. Sitoma General Hospital, Indonesia, and which belongs to University of Erlangen. He's also a board member of ACNS. So today, with great respect, let me welcome Dr. Ahmad Fahmi to chair the first session and to continue with the proceedings. Welcome you, sir.
Okay, thank you very much, Sani. Thank you very much, and Raja, thank you, and all of the faculty of the ASEAN Chairs. Nowadays, we have a speaker, Professor Pant, of the stereotactic and functional neurosurgery in Nepal. More than 20 years doing the stereotactic and functional neurosurgery. And he will talk about the role of nurses in drug-resistant epilepsy. It little bit changed than detail before. And after he explained about that, we have a discussion. We will have a discussion. The participant can write the discussion in the question and QA, question and answer tab, or you can raise hand. You can raise your hand. Okay. Actually, I am now in the Basant Prof Pant place now in Annapurna Neurological Institute and Allied Sciences in Nepal. Yeah. Now I am in Nepal now. Okay, please, Professor Pant, you can start your lecture and we can follow your lecture. Thank you very much. Thank you, Sani.
Please unmute your mic, Prof.
Please unmute, Prof.
Yeah, thank you,
okay.
Dr. Fahmi, for your nice introduction. And it's so nice to have you in Nepal. We are working together for 3 days. So this is our collaboration. We work together many times. And thank you, Sani, for your opening remarks. And actually, initially I was told about multiple lesioning in thalamus in epilepsy, but then I eventually knew that I had to, mainly my audience will be mainly nurses. So I thought that I will little bit change the topic and make it more adjustable to my audience. So it's nice to see Dr. Raza after so many year maybe, and I met him many times through Zoom, and it's so nice that you guys are continuing this Zoom in ACNS. And so I start my talk about the role of nurses in drug-resistant epilepsy. I will talk about what drug-resistant epilepsy is and then gradually move on. So just a single word about epilepsy itself. So as you all know, our brain function by electrochemical synapses, and there is an electrical current that goes, and then there is a synapse in between where there is a chemical, then again an electrical signal goes. And whenever there is an abnormal electrical signal, then there will be there is a possibility of having a seizure. But our brain is having seizure all the time. All of us are having small seizure, small abnormal activities in our brain all the time. And this, electrical abnormal activity is already suppressed in our brain by some kind of chemical so that it do not spread. But if that balance tips up, then we start having seizure. So if the seizure happens in one place, then that has to travel from one place to another, and that is the movement path of the epilepsy. So generally, it's passed through the fiber matters, through corpus callosum, or different other routes. And so the best medical management, the best management for epilepsy would be to give medicine, but only about 50% of the patient with epilepsy can be controlled by one medicine. So you have to keep on raising the medicine one after another, and creating more complications because of many drugs. So the chance of seizure becoming seizure-free, the patient becoming seizure-free after 2 drugs become almost only 1%, and as you add on, you only increase the complication. So what is drug-resistant epilepsy? The definition of the drug-resistant epilepsy is if you give 2 appropriate anti-seizure medicine in a good dose in more than 1 year and still you are having 1 seizure per month, then you can call this as a drug-resistant epilepsy. And these are the patients who will not be helped only by medicine, and they need to be treated surgically. So this is a video of a very complex partial seizure. It is a temporal lobe epilepsy. And when he has seizure, he has a motion arrest. He stops talking. He has got some fear in his chest, and his left arm is not moving, and he is moving his mouth as if he's chewing something. His right hand is moving on his thigh, and he is looking around. Okay. So these are very typical example of a temporal lobe epilepsy. And these patients, the temporal lobe epilepsy generally goes into drug-resistant epilepsy very soon because they are not very good candidate for medical treatment, but they are very good candidate for epilepsy surgery. So this, what I have just shown you, is one of the type of epilepsy. There are many types of epilepsy depending on where it is originating from. From the frontal lobe, you may have different type of epilepsy. From the temporal, if it is right side, there's different. If it is left side, there's different. And parietal, occipital, all have different type of epilepsy. So by semiology or symptom, you should ask the patient very carefully, what is your symptom? And is it all the time same? So you have to record that, and then that is very strong evidence of where the seizure is coming from. Then we do regular EEG, and then we also do a MRI, preferably 3 Tesla MRI, but 1.5 Tesla MRI is also equally okay. So if all these 3 things match, and if all 3 things show that it is coming from, like in this case, there's a left temporal hippocampal sclerosis. If the semiology, EEG all say it is from the left hippocampus, then you can go and take it out, and the patient will be completely seizure-free. So this patient will never be seizure-free, will become completely seizure-free after surgery and will have a new life. So as a nurse, you should encourage this kind of patients, identify that these are drug-resistant epilepsy and what type of epilepsy, and then maybe encourage them to get surgical management. And so another place that we have to be we have to study in detail is thalamus. So whenever there is a seizure that comes from the cortex of the brain, it goes to the thalamus, and then it again goes to the cortex. So it's called corticothalamic loop. There's a loop going on. And sometimes thalamus is the origin of the seizure. Sometimes the thalamus suppresses the seizure, or sometimes it modifies. So these days in our institute, we go to thalamus in very difficult epilepsy cases and manipulate that area so that the seizure is stopped. And I'll talk about this later in my lecture. So once we have many information, EEG, this history, then you should know where the seizure is coming from. And that is the point that you should go and tackle and take it out, okay? So this is called seizure onset zone and epileptic zone. So I'll give you an example. If somebody comes with a tumor like this, it's a ganglioglioma in the right temporal lobe, in the hippocampal area, and they come with complex partial seizure, we operate on them, we take out the tumor. The patient is saved or cured from the tumor, but the patient is still having epilepsy. So in such cases, you have to do not only remove the tumor, but also do epilepsy surgery by studying that area much further and removing appropriately. So these are some of the best cases like mesial temporal sclerosis, tumor-associated seizure, just like I showed you, drop attack where people just fall down, focal cortical dysplasia, and so on and so forth. And to start epilepsy surgery, you don't need much of an equipment, which I will explain again. So this is a basic EEG machine that we started from. This is an EEG machine that we had for our outpatient department. So whenever we had an epilepsy surgery, we'll take the same device into the operation theater and use all these leads. Once we open the brain, we all use all these leads, a sterilized lead, on the surface of the brain and look where the seizure is coming from. And then after some time, we know, oh, these are the places where the seizure is coming from. Then we can remove that part of the brain. So these leads have different size, different shapes, different numbers. And most of these leads are use and throw kind of thing. But then in our institute, we don't throw it. We can sterilize it and reuse all the time so that the cost to the patient is minimized. I'll give you an example of a tumor associated with seizure. Here, there is a tumor in the right side of the brain, and which is near the hand area and near the left hand area, which is seen in the functional MRI, and also, close by the leg area as well. So just removing that tumor may not be enough, but then if you remove too much, then you may give a lot of deficit to the patient. So in such cases, we open the area and then we do surface EEG by putting our leads on the surface of the brain. That is the tumor over there, a little bit white. This yellow line is where the motor area is, so you have to avoid that area. And you can see that it is firing. A lot of firing is there. So epilepsy is actually coming from anterior aspect of the tumor. So after doing a lot of study, then we know these are the places where we need to remove, and these are the places that we need to leave behind. And that is the end of the surgery. The patient have complete motor function of the hand and also seizure-free, and tumor is also removed. So this is something that if you are starting epilepsy surgery in the beginning, these are the simple things that you can start with. Another case I did many, many years ago, 2002, this man has got a temporal lobe epilepsy, right-sided hippocampal atrophy. So in such cases, this is very typical surgery by removing the temporal lobe and as well as the amygdala and hippocampus. And every time, first time I did it with my teacher, Professor Arita, and then every time he comes, this gentleman who is seizure-free after the operation for the last 23 years, he always come and meet him and give him some present, and he's very, very happy. So this is another very good kind of epilepsy surgery that you can do. where you can see that these children just fall like this, and if there is something that is there, then they will have injury. They fall like 30, 40 times a day. And then if you can see this boy, he is having drop attack maybe 10 to 20 times. He has many, many wounds in her face. And his mother cannot take him to the hospital every time because he is having 10 injury a day. So these are very, very bad kind of epilepsy. And in such cases, you can just cut the brain into two half, which is called corpus callosotomy, and split the brain right and left, and so that the action potential do not travel from one place to another. So this is how you cut, and the whole of the brain is split into two parts. So this is very good, effective treatment. The complication is very, very low if it is done in very early age. Maybe below 10 is best, but you can still do it in adult also. So we do a lot of this kind of surgery also. And then we started doing some burning of the tumor, which is giving rise to a lot of epilepsy, like in this case, where you can see there are tumors in the hypothalamus. And this one is the origin of the gelastatic seizure in this hypothalamic hamartoma. So we made a lot of radiofrequency listening, burning of this area. And then we have 3 cases like this, and all of the patient became seizure-free. So then came the era of neuromodulation in epilepsy. So as you go on, you start getting all these difficult cases where there is no place that you can remove, or there is no place that you can disconnect, like corpus callosotomy. And in such cases, you can do a vagal nerve stimulation, deep brain stimulation, or responsive neurostimulation. These are 3 kinds of technique that you can use. But all 3 techniques are very, very expensive. So since we were doing a lot of listening, radiofrequency listening in movement disorder that I've talked in ACNS in before also, so we had a lot of experience. So we are thinking, can we make lesions, then making deep brain stimulation, And then this is the kind of probes that you use, and we test it in egg, and then do different things. Now, I'll give you some example of these difficult cases, like this 27 years old young lady had complex partial seizure of temporal lobe type for the last 12 years, and a very, very aggressive type of seizure. She was having many, many seizures, and she also had, because of seizure, she was having limbic system problem, and she was having suicidal tendencies, and she has attempted to suicide many, many times. She has a lot of hand cuts in it. And EEG suggested right-sided epilepsy, but MRI showed bilateral hippocampal sclerosis. So we don't know which side to go, right side or left side. So here we put stereotactic EEG like this. So this stereotactic EEG is a very fine cables that you can put into the brain in multiple places. Here we have put in amygdala, hippocampus, hippocampal body, and then superior temporal gyrus like this, with a frame. And then you can see these small, small wires are giving fantastic information to us from the depth of the brain. And you can see that there is an abnormal spikes that is happening in the hippocampal body, not even the hippocampal head, not in the amygdala, and not in the temporal lobe, but it is starting from the hippocampal head. And then gradually it is spreading to the other places like this. And then eventually we knew that the hippocampal body is the point where this lady is having seizure. And we do this intraoperative EEG again after opening the brain and see that there is a lot of firing in the brain in that area. So we remove that part, and then they become seizure-free. Now, in the West, they are putting deep brain stimulation. I think deep brain stimulation itself is a misnomer because the deep brain stimulation do not stimulate anything. It actually jams the brain. So it's like a suppressor actually to that part of the brain so that the electrical signal do not travel from one place to another. And there's always fight between DBS and radio frequency listening. And we are more for radio frequency listening. Initially, we thought this is a good technique because our patient cannot afford. But now this technique is so good that even the patient say, please put DBS in a cases where we think radio frequency listening is better, then we say, no, we do not want to put DBS, but we want to give listening to you. Okay? So recently we have, for the last 2 years, we have acquired a robotic arm, and then this is a Chinese-made Remebot. And with this, we can put a lot of stereotactic EEG at one time. Otherwise, if we put these with a frame, then it takes a long, long time. And initially, we checked whether the Remebot or the frame is showing the same place or not. And we wanted to confirm, and then we can see, as you can see here, that both of the targets are accurate. So here is a patient where we has put again hippocampal in the hippocampal head. You can see that the SEEG has started firing, okay? And then it has gradually grown up and involve other parts of the brain, and then eventually the generalized seizure. So it's starting from hippocampus, going outside and generalizing and to the both side of the brain. So in such cases, we came across a trial called Sante trial in America, where they just go and make some lesions in the anterior thalamus of the nucleus thalamus. And the seizure reduction rate is so high, 75%, and seizure freedom is almost 18%. So this was a good technique, but I was not very keen to use this because this is not affordable to our people. Then I came across this paper from Stinikov, this gentleman on my right side. I'm on the left side. He's from Russia, and then he has published a paper that he has done anterior nucleus DBS and anterior nucleus radiofrequency Nizzli in the same group of patient, and then seen that the result is almost the same. So I was so encouraged by this paper that we said, okay, let's go and start this surgery. So we decided to target anterior nucleus of thalamus and first, which represent anterior frontal lobe, temporal lobe, and cingulate gyrus. And it goes into a small fork-like area. So if you go and make some lesions there, then you can disrupt the propagation of the seizure from one place to another. So this is our planning, and this is how we go to the anterior nucleus of thalamus. And then when we are doing this technique, we also put surface electrode in the head, and we stimulate anterior nucleus of thalamus and see what happens to the surface of the brain. And the surface of the brain, if we stimulate with high frequency, then there's a lot of increase of seizure activity. But when we do it with 5 Hz, low frequency stimulation, the seizure intra-ictal discharge is less. And then, okay, then we started doing this. This is a gentleman, 33 years, right-handed gentleman with maybe frontal seizure, we don't know. History is not very clear. And MRI is normal, it's a negative, so we don't know where to go. And his video EEG shows maybe he's having seizure from the left frontal, but we don't exactly can confirm this. So this is the first case where we put endothalamic lesion. We made an endothalamic lesion, and the patient became almost completely seizure, not completely, but almost completely seizure-free. Almost 90% of his seizure went away. This is another case where, this is a patient who have a hypermotor seizure. He suddenly wakes up from sleeping, and then he has very, very severe seizure. And sometimes he has injury into his body. And he's having 2 to 3 times seizure like this for the last 11 years. We can see that he's having seizure from the right area of his temporal lobe. And there is actually a lesion there. So the possibility of taking out lesion is there, but then this may not stop his seizure because he had been having this seizure for many, many years. So he already have secondary focus somewhere in the brain. So we decided to do corpus callosotomy together with anterior nucleus of thalamus lesioning in this patient. And both of the thing was done together, only one on one side. The ant lesion was made, and he became completely seizure-free. Another case where you have a insular tumor we removed many, many years ago. He is static, there's no growth after many years, but he started having seizure. So we don't want to go in and take out the tumor, but in this case, again, very simply, we went and made the lesion on the anterior nucleus of thalamus. But in a case like this, where this is a 9-year-old boy with having a focal impaired awareness seizure, and he also have a lot of brain atrophy, and he is mentally retarded. So these are very bad cases, So there is a very high chance that this patient is having a multifocal seizure. That means the seizure is coming from many places in the brain. So when we did a video EEG, which is the first requisite of epilepsy surgery, then we found that the left side of the brain, mainly the frontal, was the culprit, but then they were also right-sided independent. So sometime he was having left side seizure, sometime he was having right-sided seizure. Again, we did a similar thing. We put a lot of leads in his head, and then we did lesion on anterior nucleus of thalamus and centromedian nucleus, both sides. So as we went on, then we started realizing that there are cases where anterior nucleus of thalamus lesioning alone is not enough. Then we did some study, and it's well known that the thalamus is represented by different parts of the cortex. The yellow cortex is represented in yellow part of the thalamus. The brown is represented in brown. So if you have a seizure coming from the brown part, then you have to go to the thalamus in the brown part. So thalamus is also segmented like this. So then we came across this paper from Mayo's Clinic where they have put 2 leads on each side of DBS, one on the ant and one on the centromedian nucleus, because they think the seizure is appearing from a wide area. And as you can see on the axial image here, the 2 separate leads have been placed. So we said, if we can do anterior, why not centromedian as well? And there's another paper in Journal of Neurosurgery which also said they have even placed on 2 levels and 3 levels and multiple battery in their body, So this is another representative case where this is a case where this is a lady which has a cortical focal heterotropia of her brain, and which is right on the sensory and motor area. She was having a very, very severe painful seizure. Whenever she had seizure, she had a lot of pain, and she was having 13 to 14 seizures per day. And so the life was miserable for her. And this is right in the very important area of the brain, so we cannot remove everything. If we remove everything, she will be paralyzed, and then she will not have sensation. It's a 22 years, a very young lady. So we looked at this and saw that it is coming from the area that was abnormal on the same side, but we don't know where exactly it is coming from. So we decided to cover her and also her centromedian nucleus and also her pulvinar. So 3 thalamus targets were studied together with a study of the heterotropia. So these are the wires that is passed on our brain by a robot. And so to do this, only robot is, because by doing by hand, it takes a long, long time, maybe 6-7 hours. So heterotropia, centromedian, and pulvinar. Every targets were covered like this. As you can see, every targets were covered by different leads. And then we saw that in the interictal state, when she had no seizure, continuously there was abnormal firing from the heterotropia itself on the surface of the brain. But when she started having seizure, then after 1, 2, 3 seconds, the heterotropia seizure was moved to pulvinar first, and then it went towards the centromedian nucleus. And then when the seizure was terminated, then these activities in this area also terminated together. So now we had a very clear-cut information that the heterotropia was the one where the firing was started, and they mainly went to the pulvinar, but also in the centromedian, and none of the waves were going into anterior nucleus of thalamus. And when we stimulated that part, then she had this seizure that she always have. So we again confirmed that that is the place where the seizure is coming from. So then the thing is easy now. So we made centromedian and pulvinar lesions like this on the left-sided picture, and also multiple lesions on her heterotropia. And she went home after 2 days of surgery and have almost no seizure, or sometime a little bit of tingling sensation, but her life is, very, very good. So if you have to remove all these lesions, then you will definitely create a lot of problem to her. So at the end, maybe again, role of nurses in epilepsy surgery. This start, I think, from preoperative state, because I think there's a lot of role for you to educate the patient and also the patient party. And then you also have to work as a coordination, because many people are involved in epilepsy surgery, and and I think nurses are the very good person who can connect neurosurgeon with neurologists, epileptologists, to the biomedical engineers, and so on and so forth. And many of these people also have a lot of psychological problems, because they have been having a seizure for a long, long time. Otherwise, they are healthy, And then, that is also a role that can be played by nurses. And I think the nurse should be completely aware of what is the action plan. In our institute, when we are doing epilepsy surgery, then most of the time the nurse are totally briefed about what is our action plan, so they can, plan intra-op and post-op management. In intra-op, preparation of all necessary equipment, because we need a lot of equipments in this. Sometime robot, sometime navigation, sometime ECOG, leads, radio frequency listening devices. So this has to be prepared. A proper, functioning of them have to be verified. So we also ask those nurses who have been trained to do these epileptic surgery, nurse, scrum nurse. So we generally involve them in this surgery. So now our trained nurses are so good that they can read the intraoperative EEG themselves, and they can say, oh, the epilepsy is coming from there. Even the nurse, they guide us sometime, there's still there kind of thing. So if you involve the same kind of people again and again, they become more matured on that. And sometime during this surgery, we are doing awake surgery, or very light anesthesia is given, because we don't want the ECOG to be damaged. So that way the patient can have seizure during this surgical time. So what to do if the patient have seizure? Generally we put cold water. So ice water should be ready, and then they start pouring the ice water in the brain, or give some medication so that the seizure stops. About the post-operative management, most of the time the monitoring and care of the management are done by the nurses. And the video EEG that we do pre-op are also done by the nurses. And of course, the medical management, and sometimes we even give them the authority to inject, it's already prescribed. They can, add some prescription and then give some medicine on their own also. And also post-operative education, if they have some seizures, they should say, sometime it takes time for the seizures to be completely, or and again, it's a collaborative effort. And then I think the nurses are the focal person who can link patient party, doctors, and within the doctors also many faculties as well. So video EEG is mostly done by nurses in our institute, and then whenever we want to have them have seizure, so we do it for 3 to 4 days. And if if their seizure is not that frequent, then you need to stop the medicine, or maybe reduce the medicine to half. And patient and family will ring the bell when the seizure comes. So the nurses come running, and then they go to the patient, and they have to examine, talk with the patient, and see how she is responding. Look at the people, because people generally dilate when they have seizure. If they don't have seizure, then there's no change in the people. So many things they have to do, and record their behavior at that time, what they did. So everything has to be recorded. And if the patient have multiple seizures, we want at least 3 seizures during this 4 days period. But if they have multiple seizures, one after another, then they have to treat this as a possible status epilepticus, and these are always told them. And we also have EEG technician in the same room, so they need to cooperate with the EEG technicians as well. Well, with this, I end my talk. I'm sorry, this may be a little bit too technical, but then if any of your institute is already doing or wants to start epilepsy surgery, and you need training on that by nurses, then you are most welcome. We always have visitors from another country. Nepal is a beautiful country and nice peoples. These are our residents, and then you can enjoy your stay in Nepal as well. Thank you very much.
Okay, thank you very much, Professor Pant. It is very comprehensive lecture. Yeah, I saw by myself during my stay in Nepal. They are very collaborative between the doctor, nurse, and Professor Pant team. Yeah, in Annapurna Hospital. Okay, thank you. And next, it is about. I invite the commentator to give the comments. Professor Zhang and Miss Tia. Maybe Professor Zhang first, please. Prof. Zhang. Do you have any comment? Thank you, please.
Hello. Okay. Professor Pang, thank you very much for your lecture. It was very comprehensive, from the semiology, MRI, and to EEG, and also many encouraging cases under surgery. The work of radiofrequency of the thalamic nucleus sounds very exciting. I am a bit curious about the issue of the post-operative complications about radiofrequency. Could you please talk something about the complications?
Yeah.
Thank you very much.
So we have, on epilepsy cases, we have only 14 cases where we have done thalamic lesioning. So our number is still small. And all of these surgeries are done on awake state. So majority of complication of targeting the wrong places, and then you can check it during surgery itself by doing stimulation. Just like DBS, we stimulate that part, and then we make test lesioning, which is reversible lesions. So we make a small temperature, like 50 degrees Celsius for only 30 seconds. And then if something happens, we stop it in between. So once everything is okay, then the chance of having complication would be very, very low. This is our experience, but we have a lot of experience on movement disorder since many, many years. So we just started this on epilepsy recently. But delayed complication that we have seen on movement disorder, which can apply to epilepsy surgery also, is two cases out of 300 cases or so, 2 cases of hemiparesis, delayed hemiparesis about 6 to 7 days after surgery. So this happened, we did an MRI and we saw that there was a distant infarction away from the lesion that we have made. So this is most likely a small perforated that has been coagulated, which was passing through that area, you know, and then they had a distant coagulation effect. So this is one thing. And if we are doing bilateral, we don't know about, so on epilepsy, we are doing bilateral anterior nucleus thalamus lesioning. And most of the places are not very away. Thalamus is pretty safe area, you know, but we don't know. There are some speculation that if it's a dominant area, then you may have some memory impairment, or you may have some cognitive impairment. But at least in our cases on bilateral, we have not seen this. So it's pretty safe technique, but we cannot say for sure unless we do a lot of this surgery, you know. Yeah. Thank you.
Okay, thank you, Prof. Zhang and Prof. Pan. And the next will be Miss Tia Marina. Please give your comment, because the nurse is our front line. Yeah.
Yeah.
Every time patient meet with the nurse, not every time with the doctor. Please, you give your comment, Miss Tia. Unmute, please. Unmute. The sound is coming. Okay.
Thank you for thank you for the opportunity that given to me, Dr. Ahmad Fahmi and Prof. Basant. And then thank you for very insightful presentation, Prof. Basant. As a nurse who involved in perioperative management, this topic is very important for us. But sometimes in low result setting where advanced therapies are limited, what can nurse do to optimize care and safety for the patient in drug-resistant epilepsy? And then my second question, what kind of long-term follow-up and counseling should nurse provide for patient after successful epilepsy surgery? Thank you.
Thank you, Tia. And this is a very important question that you have put. One is, I say, this is a functional neurosurgery and very, you know, sophisticated surgery. So to reach to this level, I think you should go gradually. And your institute, if they are doing, then they should do best case candidate, you know, where the result is more than 80 or 90%. Like temporal lobe epilepsy, it's more than 90% in our institute. So these are very, very good cases. The result is extremely good and the patient is extremely happy. And even if they have seizure maybe once a year or twice a year, so it's not a big issue. But if you try to do something very complicated without having a proper information, then this is a problem. This is one. And secondly, my training was in Japan. And then in Japan, they have a concept that if you are doing an epilepsy surgery, then you should know how to read EEG yourself, or at least verify the EEG that is read by other people, so that you say, okay, this candidate that neurologist has sent me is a good candidate. You should be able to verify, not only operation, but you should study these EEGs. So this is another important thing. And about long-term management, you know, generally we say we give anti-seizure medication, ASM, for about 2 years post-op. And if they have zero seizure, and if they have no aura, because aura, if they have just aura feeling of having seizure, then that is also seizure. They are having actually seizure, but in a small scale. So aura is not good. So zero seizure, zero aura. And if the EEG is pretty good, or maybe few only abnormal waves, then after 2 years, we have been able to stop medicine in many of these cases.
Thank you.
Thank you
very much.
Dr.
Thank
Basant.
you very much, Prof. Pan and Ms. Tia. From participant, is there any question? Please, you can raise your hand. Oh, there is one raised hand from participant. Jadi Subianto. Is there any opportunity to make he can speak from here?
So today
Oh,
this
please.
lecture is also being listened by about 20 nurses in our institute. And then, you know, it's so nice that they can be linked with all of you.
Yeah, thank you, Prof. Pant, for the support. Yeah, many nurses here
Yeah,
join in another room.
yeah,
Okay, please, Dr. Harry, you can ask.
Hello. Good evening, Prof. Basant. Nice to meet you again.
yeah.
Very nice lecture, and we have a lot of information from your presentation, especially doing hypothalamic hamartoma lesioning and also the ANT lesioning, because otherwise we have to do the DBS, where the DBS is sometimes quite difficult.
Yeah.
Actually, I would like to ask about, is there any support, or how the ACNS will support the young epilepsy? Like me, I'm working with Dr. Fahmi, Prof. So we are working in Surabaya. We start our epilepsy center, but mostly our problem is to get the specific equipment for recording. Sometimes for subdural electrode and also the tape electrode. We have the equipment to implant, but the implant itself is quite difficult. So is there any support from the SCNS maybe to encourage us, especially in the limited resources country, especially, yeah, to get more about this equipment so we can do more things to help the people. And also, actually, the INT DBS, we are waiting also for the result, Prof, because sometimes we cannot resect, so we just wait. So with your result in INT listening, we hope that we can have some, because in Indonesia we cannot just do the procedure without having the clinical guideline. So if we have some other part has already performed this and the result is good, we can adopt as our clinical guideline, and then we can do routinely in our center. Thank you so much.
Yeah, thanks, Hari. And maybe somebody from ACNS can reply on his queries about the support from ACNS, technical and as well as technological support. From my side, I can say that our center is WFNS training center. So if you want to come, or anybody can to come to our institute, we can provide you with free lodging, a free place to stay, and a food for up to 3 months, and then train you on epilepsy surgery. Maybe less technology involved, so that you can immediately go and use it in your country,
Yeah, okay, thank you.
Well, sorry, most of the leads that we use, even the stereotactic EEG, we reuse it. And sometime I'm so surprised that once you use it to burn, this SEEG leads can also be reused again. So they say it's don't use it again, but then you can use it, no problem. For recording, you can use it many, many times, maybe 5, 6 times. So the cost will go down.
Okay,
Yeah,
thank you very much,
Dr.
Prof.
Raja,
Pant and
can you tell something about, you must have heard
Dr.
about.
Raja, please,
Yeah,
please,
I
Dr.
heard
Raja.
that. First of all, let me congratulate you for this amazing work that you are doing in spite of the resources constraint, and your willingness to host somebody from a low income countries is more than welcome. The ACNS can provide support if they are approached. You can write to Prof. Kato directly if you need any help. Regarding the lecture, I would like to ask 2 questions. Like, when you put SEEG electrodes, like you just mentioned that you may reuse it, how do you sterilize it?
Yeah,
Does
you can clean it, and then you can sterilize with ETO or plasma.
ETO.
Yeah.
Now, does the
Slice.
electrode get some damage due to ETO or something like that?
No.
No,
Another
doesn't get
way is, if you don't have a ETO or plasma, then you can put it in a formalin box for at least 24 hours.
Okay.
That is not a very good idea, but then you can still use. We used to do that, but now plasma and ETO would be the best. Plasma is better than ETO because ETO has got some side effect to the nurses if they are not very careful. So we recommend now more of plasma. Yeah.
Mhm. And another question is that when you said you use the Chinese robotic arm
Yeah,
for placement, like it is navigation guided, isn't it?
yeah, yeah.
Okay, good. So, like how much time do you observe the patient for abnormal electrical pulses? Usually 2 weeks.
No,
No.
we never observe for 2 weeks. It's too long. And most of the time, these patients are having seizure all the time. And 3-4 days, we are already clear, Even if
Yeah.
intra-ictal, some small ictal events, even if they don't have full-blown seizure, you can have small seizures. So by 3 or 4 days, we already know.
Yeah.
So
So in that period, you withdraw all the AEDs, isn't
yeah,
it?
we do all the EEG. In other places, they cut it. We take the screw out.
No. I'm asking that when you put the SIG, you withdraw the patients of the
Yeah, we take it out and
anti-epileptic drugs.
So I told this in my lecture. So if the patient is having too many seizures, then it's dangerous to withdraw it. So if they are having, let's say, 1 seizure per week or something like that, then you may not have seizure during your study. So we make it half. But if they are having daily seizure, then we don't withdraw anything because it will be too dangerous. They may go into status epilepticus.
Okay. So thank you very
Thank you
much.
very
We
much.
can take final remarks from our chair, Professor Ahmed Fahmi.
Okay, thank you very much. It is a very nice lecture. Thank you very much, Professor Pan, yeah, Dr. Raja, Miss Tia, and Prof. Zhang, yeah, for the comment and the very wonderful lecture. I think there is the nurse. It's very important in the surgical area, especially for in the functional. Before surgery, during surgery, and after surgery, we need to make a good collaboration between the doctor, nurse, and other staff. The collaboration is very important to make a good outcome for the patient. Okay, thank you very much. No, and then I continue the session. I give back the speak to the Sunny, Miss Sunny.
Okay.
Please, you can continue. Thank you very much,
Yeah,
Prof. Pan, Dr. Raja, Prof. Zhang, and Miss Tia. Thank you very much, and
Thank
all
you.
of the participants.
Thank you. Thank you, Dr. Fahmi, for chairing the session. And thank you, Dr. Pant, for sharing your wonderful experience with us. But unfortunately, we were not aware of the topic. Otherwise, we would have scheduled a nursing session of the similar topic so that we could have more discussion on the nursing aspect in the seizure management and optimizing seizure medications and epilepsy surgery management and all. But definitely, we will have another set of webinar in which we'll be covering those areas also. But today we have scheduled another session regarding the nursing care of patient undergoing surgical management for movement disorders. And for that session, I would like to welcome Dr. Angela Gnanadurai for chairing the session. And Madam is the president of Society of Indian Neuroscience Nurses, and she is currently retired. She had her post-graduation from CMC Vellore, and she had her PhD in nursing also. Madam is a very eminent person in leadership, taking many leadership role in different areas, and she had mentored many nurses, including me. And I'm really honored to welcome Dr. Angela Gnanadurai to chair the session on the nursing management of patient undergone DBS surgery. Thank you. Welcome, ma'am.
A warm good afternoon to each and every one of you. It's my honor and privilege, and it's my immense pleasure also to be part of this webinar. I'm very happy to listen to that previous session by Professor Basant, and he had brought us to the very practical area of in seizure and seizure management, and it has been a great opportunity for all of us. And it was very heartwarming to listen from him that they are very open to train all neuro nurses who are neuro nurses and all the other healthcare workers, whoever wants to take training under him, 3 months, they are willing to provide food and accommodation free to go and learn. That really shows their how committed they are, how very happy they are to train, and especially for the care of the patients with epilepsy, who are very closer to their heart. Thank you very much, sir, for this opportunity. We will try to encourage many youngsters to come and learn from you. I'm sure that will give a very complete care for our patients and their quality of life, which can be improved dramatically. Coming to this second session, I'm very thankful to the organizers for including me for the chairing the session, and I really congratulate Shani for organizing it with the Professor Yanko and also other members of ACNN and executives of ACNN. And I, at present, I'm very happy to introduce Mrs. Nirmala, and she's the nursing superintendent of Sri Chitra Trinal Institute of Trivandrum, and she has 33 long and excellent years of nursing experience in her career. And Madam has been part of various national and state level conferences, and she has organized various educational programs at the state, national, and national level. And she's a very active member of the Society of Indian Neuroscience Nurses, and she encourages all her nurses. Many of them participate very regularly in the annual conference of Society of Indian Neuroscience Nurses. I'm very happy to invite her for presenting on pre and post-operative management of patient with deep brain stimulation, which is the upcoming very good technology for our Parkinson's patients and patients with the movement disorder to improve in their quality of life. So over to Mrs. Nirmala.
Thank you, ma'am. Am I audible? And hope that my screen is visible to. So deep brain stimulation is a neurosurgical procedure involving the implantation of a neurostimulator into the selected area of the brain to regulate the activity of various structures in the brain. So it sends electrical impulses through implanted electrodes to specific targets in the brain, especially the brain nuclei, for the treatment of movement disorder and neuropsychiatric disorders. So the introduction of this stereoencephalotomy dates back 1947, and the pioneers were Spiegel and Weiss. This tool was mainly used for the localization of ablative procedures, and the modern DBS is attributed to Dr. Alim Benabid, who discovered that this electrical stimulation of the basal ganglia which improves the symptoms of Parkinson's disease in late 1980s. So this is the development of modern DBS. It dates back 1947, and in 2020, wireless DBS system has been developed. These are the components of the deep brain stimulation. Mainly a lead is which is made of platinum, and it is connected with the wires, and the lead will be implanted deep into the brain structures with the help of, we are making small holes in the brain, and we are putting the lead into the different areas of the brain, and the lead is connected through an extension to the neurostimulator. This neurostimulator is implanted below the clavicle level. A pocket is made in the below the skin, below the clavicle level, and the neurostimulator is implanted there. So these are some of the indications of DBS. As sir, in the previous session, we have seen that for the epilepsy treatment, we are using DBS. Mainly, we are using this deep brain stimulation for essential tremors, Parkinson's disease, generalized dystonia, Tourette syndrome. Tourette syndrome means tics, some verbal as well as motor tics, for the treatment of tics or obsessive compulsive disorders, and for some chronic pain. This deep brain stimulation is used. In our situation, we are mainly used for essential tremors and Parkinson's disease. The target site for the stimulation, the target site for the implantation of these electrodes are In the case of treatment for stiffness and tremors, we are putting the electrode in the subthalamic nucleus. And for the management of dyskinesia, the electrode is placed in the globus pallidus interna of the brain. And the thalamus also, we are putting the electrodes. So the selection criteria for patients with deep brain stimulation for the Parkinson's disease, patients who are having Parkinson's disease, who are selected for the deep brain stimulation, because a patient is having Parkinson's disease more than 5 years, and there is on and off fluctuation with or without a dyskinesia is there. If the symptoms of this Parkinson's disease interfere with the daily activities, quality of life of patient is declined, then the patient is a candidate for deep brain stimulation. And disabling medication resistant tremor. Even after taking adequate dose of medication, there is medication resistant tremor. And continue to have a good response to PD medication like a carbidopa or levodopa, and want to reduce the dosage, then also we are doing the deep brain stimulation. We have to exclude the atypical and secondary Parkinsonism. If the patient is having any dementia or depression and the medical condition of the patient is not good, that patient also needs to be excluded from this deep brain stimulation. So the advantages of deep brain stimulation is it is reversible, and whenever we need, we can change the voltage, and some adjustment can be done in that stimulator. And it improves the quality of life of the patient. As I told you earlier, help to reduce the medication, and it is a relatively safe procedure and improves the energy level of the patient. So some disadvantages are there. It is highly expensive. The procedure itself costs about 18 to 20 lakhs, including the surgery, the charge for the surgery. When we use a rechargeable battery for the DBS, it costs about 18 to 20 lakhs. And the life of the battery is about 14 years. And if you are using a non-rechargeable battery, the cost is 15 to 16 years. And the battery life is only 3.5 to 5 years. And if we are changing the battery, the battery change itself costs about 8 lakhs. So it is for the people in the middle and the low income countries, when we consider these people, it is highly expensive. And there is increased risk of infection, because we are implanting a foreign object into our body. So there is chance for infection. And the long-term outcome is, we are not sure about the long-term outcome. And as I told you, it need a replacement of these batteries. So the pre-operative nursing care include first assessment. We have to a comprehensive assessment of the patient's motor symptoms, cognitive status, comfort level, other comorbidities, etc. We have to assess. Studies indicate that the pre-operative cognitive function like memory, fluency, etc. predicts the post-operative motor outcome. Evaluate the medication history and the symptom diary. So usually the patient will have to keep a diary related to their symptoms. So we have to evaluate their medication and the symptom diaries. Develop individualized care plan for each patient. It is a multidisciplinary team approach. It includes the neurologist, neurosurgeon, and the rehabilitation team. So coordinate with this multidisciplinary team. Then patient and caregiver education is very important. We have to educate them what the procedure involves, what to expect out of this procedure, what device we are using, what are the potential risks and benefits, what are the post-operative care involved, and the device precautions. When we are putting the device, the patient has to take some precautions like electromagnetic interference, MRI safety, etc. That we have to educate them in an understandable terms. Review shows that tailored multidisciplinary education and interventions enhance the patient autonomy, satisfaction, and physical performance. And we can use any method of teaching, like verbal teaching or written material. We can distribute some written material. If any digital apps available, we can use that digital app, or question answer method we can use. We have to include the caregivers also, because it is a chronic disease, and lifelong they have to take a treatment, or they have to manage this DBS, and also the caregiver involvement of the caregiver also is important when we are educating the patient. educate on the procedure, risk, and expectations. In one study, 2/3 of the patients and caregivers felt fully prepared for DBS surgery after teaching we have given. Then we have to document their readiness, ensure their understanding. We have to take their consent, and psychological preparation is very important. Safety and risk reduction. We have to assess the preoperative skin integrity, then assess the nutrition status, screen for any infection like skin infection or dental infections, minimize the risk of which will minimize the risk of the device related infections. We have to send a nasal and throat swab, culture and sensitivity. And according to the report, we can start some antibiotic, we can treat the patient, then only we will take the patient for surgery. Preoperative imaging like MRI or CT is done to localize the target and screen for any surgical risk. Baseline vital signs, blood workup, medication reconciliation is important, especially when the patient is taking anticoagulant or antiplatelet. We have to stop that anticoagulant and antiplatelets at least 4 or 5 days before the surgery. We have to assess the fall risk, mobility evaluation, because the post-operative mobility may be impaired. So pre-operative itself, we have to assess the mobility evaluation. Then psychological support. Some patients experience anxiety about the surgery, so we have to give proper education for about rehabilitation. Everything we have to give to the patient. Then preparation for the surgery, skin preparation. Usually when the patient is admitted, usually before the surgery, 2 to 3 days before, after the preparation and everything, the baseline, everything is corrected, the patient will be admitted. From the admission itself, the patient is asked to take bath with the optimisan solution. It is an antimicrobial solution. They have to take bath with this solution and apply miprocin ointment to the nose and the ear to minimize the colonization of bacteria or microorganisms in this area. Full hair clipping is done on the day of surgery, and we have to prepare the body, shave the hair of the body above the abdominal level, because we have to place the neurostimulator in the body. Thorough bath after shaving and paint the body with betadine. After the preparation, we have to put sterile dress to the patient. Then usually we are giving a light dinner on the previous day of surgery, and the enema will be prescribed the previous night of the surgery. Usually the patient will be kept on NPO from midnight. Usually some anesthetists may prefer plain water or sips of water till 4 a.m. Medications, antibiotic test dose is given in the morning, on the day of the surgery, and we have to give injection pantoprazole and injection emicid as pre-op medication. Withhold the morning dose of Syndopa, and we have to administer the antibiotic half to 1 hour before the incision site. Usually injection ceftriaxone and amikacin we are prescribing. It is given in the operation theater before the incision. And before we are sending the patient, we have to plug the ear with the Prelox gel, that is a lidocaine and prelocaine, in order to anesthetize the ear as well as the forehead. We are putting this Prelox gel because we have to fix the frame, stereotatic frame, before the implantation of the electrode. Verify the informed consent and the surgical documentation. Give mouthwash with the Listerine solution before shifting to OT, because it is a practice we are following to reduce the colonization of the mouth. This is how the patient looks after the stereotatic frame is fixed. The stereotatic frame is fixed in order to stabilize the head when we are putting the electrode into the brain. So the intraoperative nursing considerations include assisting during surgery. Usually the procedure is done in 2 stages. In the first stage, under local anesthesia, after putting the stereotatic frame, the patient will be shifted to the OT, and before shifting the patient to the operation theater, a CT scan will be done to find out where is the location for putting the electrodes. So then the patient is shifted to the OT. The procedure is done in 2 stages. In the first stage, under local anesthesia, the burr holes will be put in the skull, and the electrodes are placed deep into the brain. Then during this procedure, the patient will be communicated by the neurologist and the neurosurgeon in order to evaluate whether there is any complication is there, what are any side effects during the stimulation. They will do the stimulation outside. They will through the connections, they will do the stimulation. They will see whether any complication or any side effects is there. After putting the electrode, they will put the patient to ventilator, then anesthetize, and under general anesthesia, the neurostimulator is implanted into the under the skin of the clavicle. So in 2 stages, the surgery will be done. So the nurse's responsibility is to see that a sterile field is maintained for the surgical procedure, and they have to watch for any complication for the surgery, and they have to document the procedure, where is the lead placement, the device specification, and post-surgery, the patient will be transferred to the neuro-intensive care and hand over with the neurosurgeon and the neurology team with the monitoring plan. The immediate post-operative management, that is 0 to 24 hours. Within the 24 hours, monitor neurological status of the patient. For the first 1 to 2 hours, we have to monitor every 15 minutes. Then after up to 4 hours, we have to monitor for half an hour. Then every 2 hourly we can monitor. Monitor the level of consciousness, pupil size, reaction, motor or sensory deficits, any signs of intracranial hemorrhage is there. Monitor the vital signs, incision site to be checked for any bleeding or any signs of infection is there. Pain, usually mild to moderate pain will be there. So we have to manage the pain with the analgesic as per the order. We are giving paracetamol, and sometimes we may be giving IV tramadol may be given. As soon as the patient become awake and able to swallow, the anti-Parkinson's drugs will be started. Device and lead site care is important. Put a clean dressing there and observe for any leakage, CSF leakage or any wound complication is there. And during this time, we have to orient the patient as well as the relatives, what procedure was done, how the implant was put, and the care, everything we have to explain to them during this time. Then early post-operative management, within the first 2 to 7 days, ongoing monitoring, neurological assessment to be continued. Then we have to watch for any confusion, delirium, hemorrhage, or infection, etc. Literature notes the risk of hospitalization complications such as delirium, post-DBS. We are seeing delirium in some patients. So wound care is important. Dressing is changed on the first post-operative day. Further dressing changing will be done on alternate days, and wound usually kept open after 3 to 4 days. The patient will be asked to take bath. Pain and symptom management, and we have to give effective analgesia, monitor for any side effect and comfort of the patient. Encourage the movement as per protocol. Ensure that fall precaution is maintained because post-operative delirium and weakness is expected. So we have to mobilize them very carefully. Then device activation planning. Usually the device activation will be done after 3 to 4 days after confirming the placement of the electrode with the help of an MRI. And physical early mobilization as per the neurosurgical protocol and the orders of the doctors. Coordinate with the rehabilitation team for safe mobilization of the patient. And the patient education, we have to start discharge teaching at this time. Then usually IV antibiotics are continued for 7 days. Sometimes after 5 days, switch to oral antibiotics. The switches or the clips are removed on the 8th or the 9th day, and the patient will be discharged on 9 to 10 days. Usually the patient will be discharged on 9 or 10 days. And once the stimulation started, we can reduce the dose of this anti-Parkinsonism drugs. We have to monitor the medication changes and the stimulation parameters, document the changes also. Then intermediate post-operative management, like weeks 2 to 12, device programming and the adjustment. The post-operative programming is key factor, and the nursing time is important. Sometimes some nurses are expert in stimulation of this. In our setting, our neurologist is doing the stimulation and all. We have to collaborate with the neurologist or specialized nurse for during the initial stimulation procedure sessions. Usually, before the discharge itself, the stimulation will be started, and the first review will be 1 month after the discharge of the patient, and the second review will be on the 3rd month. It is compulsory. First month, if it is needed only, they have to come. Otherwise, on 3rd month, they have to compulsory will come to the hospital, and yearly they have to review, or SOS they can review in the hospital. Rehabilitation is also important with the rehabilitation team. And we have to monitor for the complications like site infection, any intracranial infection, hemorrhage, or hardware dysfunction, lead migration, or cognitive or psychiatric changes. And the patient and caregiver support is important. All education, we have to how to take care of the device and all. We have to tell to the patient as well as the relative when they have to take precaution when they are undergoing any MRI. They can switch off that machine and they can undergo the MRI. And when they are going to electromagnetic field, they have to be very careful. And these patients are asked to avoid heavy lifting and bending over the that site, etc. for a few days is advisable. So, long-term post-operative management, ongoing follow-up care, as I told you, first month and 3rd month, and every year they have to come, or SOS they can come to the hospital. Home care and community nursing involvement is very important, because when the community health nurse is educated on this DBS care, they can give more comfort, and the post-operative management will be very easy when the patient goes to the community. Then the rehabilitation and functional optimization, coordinate with the physiotherapist or the occupational therapist to regarding the maintenance of mobility, activities of daily living, prevention of fall, etc. And documentation, we have to document, and we have to hand over everything to the patient as well as the relatives. So the nursing considerations related to risk and complications. The potential complications are surgical complications like intracranial hemorrhage, stroke, infection of the device, lead, and wound healing issues are there. And device or hardware related complications are lead migration, displacement, the failure of the implanted pulse generator, battery depletion, programming issues. Then clinical complications like confusion, delirium, post-operative, and cognitive decline or psychiatric issues, mood changes. Some patients may experience mood changes after the surgery. And rehabilitation and functional complications like falls, mobility limitation, residual movement disorder symptoms, etc. So the nursing role is mainly early identification, proper reporting and education, documentation, patient and caregiver education, prompt liaison with the neurology and the neurosurgery team. So the discharge checklist for the DBS patient include incision care instructions. Usually when the patient is discharged, we will tell the patient that they have to avoid scratching over the pulse generator site. The patient can keep a gloves on their fingers, or they have to cut short the nails in order to avoid scratching. Then activity restrictions, avoid heavy lifting, bending over initially. And device care and precaution list, as I told you, MRI safety, avoiding strong electromagnetic and mobile phone, use of mobile phones near the chest implant, airport security. In that cases, they have to take precaution. Then program follow-up, as I have explained, and the emergency, or when they have to call the hospital, or when they have to come for follow-up. If the patient develops any fever, redness, swelling at site, or sudden return of the symptoms like a headache, vision changes, or any neurological deficits, etc., they have to come to the hospital. Medication adjustment plan. The patient will be reduced, the medication dose will be reduced. They have to see for any side effects of this when we are starting this stimulation, and they have to report it to the doctor. Then psychosocial support is very important. So the role of the nurse is as educator, coordinator, and advocate. As an educator, provide tailored information to the patient and the family, reinforce at each stage, that is the pre-operative stage, the intraoperative stage, and the long-term care. In all such cases, we have to reinforce and give education to the the patient as well as the caregivers, coordinate a bridge between the neurosurgery and the neurology team, rehabilitation team, and the primary healthcare nurse, home care nurse, and we have to facilitate a smooth transition of care in the community setting. As an advocate, we have to ensure the patient safety, monitor for any complications, ensure follow-up, and allow and help them in decision making. And we have to help when we are getting the informed consent. And the lifelong follow-up is also important, because it is a chronic disease. They have to live with this disease as well as the DBS system in their body. So the summary is, DBS is a complex but effective. It's a complex disease, and management is critical across all phases. Pre-operative assessments, education, and risk reduction set the stage. Post-operative nursing include immediate monitoring, wound care or device care, education, rehabilitation, coordination, long-term follow-up, etc. And the evidence support that structured educational programs, comprehensive rehabilitation, multidisciplinary team approach, and rigorous monitoring for complication is important. Thus, the nurse's role is multifaceted as an educator, coordinator, monitor, advocate, and they contribute significantly to the patient outcome and the quality of life. Okay, these are some of the references. If you have any doubts, you can ask me, and thank you.
I think Dr. Angela ma'am can take over. I think Angela ma'am is not there. So let me call upon actually we have Professor Yoko Kata join with us. Welcome, ma'am.
Hi, how are you? It was wonderful. Just like I
I'm,
listened the last talk.
Good
It was
to see
wonderful.
you.
Yes, see you. Okay, bye-bye.
Yeah, ma'am. Oh, you are leaving, ma'am? Right.
Oh, it's okay.
Hi.
Are you having a discussion now?
Yeah, we are
Yes,
going to
yes.
have a discussion. Yeah.
Please, go ahead.
Ms.
Yeah,
Nirmala,
Angela,
it
ma'am,
was a
you can
very
continue.
comprehensive presentation, and you had covered all aspects of nursing care, including discharge and post-discharge plans. Is anyone having a question?
It's an excellent talk. Actually, madam's experience
Actually,
is
there are
reflected in the detailing. Yeah.
There are few brands of DBS, no? Which is the brand which you prefer? Can you
Here,
and what is the cost of it if Ms. Nirmala?
Madam, I told you the cost of if the battery is rechargeable battery. When we are using rechargeable battery, the cost is 18 to 20 lakhs. That is the cost. The life of this battery is 14 years. Whereas when we are using non-rechargeable battery, the cost is 15 to 16 lakhs. And the life is only 3.5 to 5 years only. That battery they need to replace. Rechargeable battery, they will be given a remote to in order to stimulate regulate the voltage in the voltage in the that neurostimulator. They'll be given a remote control. So the battery, the IPG, the implanted pulse generator, can be recharged with like a power bank. They will be given a device to recharge the battery.
Thank you. Thank you, sister. Anyone else would like to ask any questions? If there is no one, I really would like to thank Ms. Nirmala for her very comprehensive session. Yeah.
Ma'am, you can invite more commentators if they. Okay. Let me welcome the commentators if you have anything to add, Ms. Tia Marina or. Would you like to add anything?
for the opportunity that given to me. And thank you for the great presentation, Nurse Nirmala. As a nurse, I find this topic is highly relevant because evidence-based nursing care is essential for the safety and recovery of patients undergoing DBS. But I have a question. Before you mentioned about rehabilitation,
Yeah.
is there any specific post-operative rehabilitation guidelines or protocols for patients undergoing DBS, and how can us as a nurse participate in their development? And then how can we contribute about how to early detection of cognitive, speech, or mood change after DBS? Thank you.
So actually rehabilitation, in the first post-operative day itself, the patient will be asked to, the nurses, we have to mobilize the patient. In the pre-operative stage, we have to assess their cognitive level. Before the surgery itself, they will assess their cognitive level and all will be assessed. So in the post-operative period, we will again assess whether there is any decline in the cognitive response of the patient. So according to the, and we have to assess the mobility status of the fall risk assessment and the mobility status we have to assess in the pre-operative period itself. So we can take care of in the post-operative period, the patient will be, first day itself, we will, according to the level of their tolerance to pain and all, they will be mobilized out of bed, and with the help of the relatives, we will ask them to ambulate in the ICU itself. And the first or second post-operative first day itself, they will be shifted out from the main ICU to the they will be kept in a separate room. So we will keep the relatives with them, and they will help in mobilizing the patient. And the cognitive assessment, we also, their memory, everything we will assess in the pre-operative. We have a neuropsychologist here. In the pre-operative stage itself, that neuropsychologist will do a thorough assessment of the patient, and the post-operative also he will do it. And the nurses also involved with the neurological assessment of the patient. Even she is in the unit, frequent monitoring of the patients.
Ma'am, you are muted.
Thank you, Nurse Nirmala.
Yeah. Do you have a format which is very much related to your area of people, or is it a national format?
Yes, not related to our national format. As I told you, madam, we have a neuropsychologist. He is involved actually with the assessment, everything. He will keep that format. Standardized format is it.
Okay. Thank you very much. Thank you, Ms. Tia Marina. I request Professor Zioli Sang also to comment on this.
Thank you, Nirmala. What you have done is really impressive. I have a little question. We all know patients with Parkinson's disease sometimes have very obvious tremors, which make it difficult for them to remain completely stable when they have MRI scan. At your center, have you had some situations being taken in this field regarding these tremor problems?
Sir, when we start stimulating, you are asking about the tremor problem post DBS. Is it so?
No. I mean, the patient with Parkinson's disease before the surgery, they have tremor, right?
Yes.
They have to and MRI scan.
Oh, they have to undergo MRI.
What will you do? Yeah.
there I think
Sedation.
sedation we can give, or sometimes when the patient is taking no, when the patient is taking syndopa or levodopa, everything, the tremor will be controlled. And when they are stopping that medication, sometimes the patient will be fully paralyzed stage is there. There won't be any tremors, or they will be, when they are continuously on this medication, the tremors will be controlled. And if you are stopping that medication also, that they will have that, they cannot move and all. I think they are stopping that medication and we are doing the MRI.
Okay.
Otherwise,
Thank
if
you.
it is not possible, we will do sedation and we are doing the.
Okay.
Thank you, Nirmala. If no other question, I would like to thank Professor Zioli, Ms. Tia Marina for being there during the session and for making it clear of few points. And I also thank Ms. Nirmala for her very extensive presentation on each and every aspect of patients undergoing DBS, strategies for patients undergoing DBS. And on the whole, it's been a very wonderful session. And I'm sure all the participants have benefited out of it. And I congratulate the organizers, especially the ACNN executive members, Shani and Professor Yoko Kata, for all the preparation, and for months early they had prepared, and they were reminding and making sure that everything in place. Thank you once again. It's my pleasant privilege to be with you all during this webinar. And I request Professor Yoko Kato for closing remarks.
Thank you so much. I'm so sorry because I had some emergency case, so I joined a bit very late time. But I think the nursing staff, the work is very, very important, and also you're very busy preparation, and also during the surgery and the post-operative management. Maybe sometimes even busier than doctors, I think. So I very admire your work, I think. And hi, hello. So anyway, thank you very much for your dedication to the treatment of the patient, especially the functional, the neurosurgical treatment. It was an excellent talk. Thank you very much. Congratulations.
Thank you, ma'am.
Thank you,
yeah.
ma'am.
Thank you very much. And I request Ms. Shani to close the
Thank
webinar.
you so much. Thank you. We had a wonderful webinar today. Initial talk was on epilepsy medications and how to epilepsy surgeries. And later we had a talk on DBS patient undergoing DBS, how to manage it. The two sessions were very much comprehensive and we had a great discussion. Thank you all the speakers, and thank you the commentators and all. And I thank Professor Yoko Kato for joining and spending valuable time with us, and thank Dr. Raja, and I thank the session chairs of today, Dr. Angela and Dr. Fermi, then Professor Ilunga and some others are joined, the ACNN and ACNS board members. Thank you all the participants, and I welcome all you for the coming webinars also. Keep joining and keep updating with us to improve our patient care around the world to benefit all the patients around us. Thank you. Thank you. See you all again during coming webinars. Thank you so much. Have a great day.
Thank you.
Thank you.
Thanks so much.
Thank you very much.
Thank you. Thank you.